recording and give a little intro, and then we can go ahead and start the presentation. So first, I would like to thank all of you guys for being here today for the shadowing session. It means a lot. I hope you will get a lot out of this experience, and a bigger thank you to Dr. Riches for being here with us to share her experiences, and we will learn a lot from you today. Dr. Marcie Riches is a bone marrow transplant physician, director of the bone marrow transplant program here at UNC, professor of hematology. Dr. Riches received her MD and completed an internal medicine residency at the University of Kentucky, completed a hematology and oncology as well as stem cell transplantation fellowship at Northwestern. She has a master's in clinical investigation, which she uses for research in cell transplantation and immune response post-transplant, focusing on bone marrow and stem cells used to treat leukemia and lymphoma. Further, she is a scientific director for the Infection and Immune Reconstruction Working Committee for the Center for International Blood and Marrow Transplant Research, which collects outcome data for transplant centers worldwide. Thank you so much for being here again, and we look forward to your presentation.
You are very welcome. That was a wonderful introduction, Isabel. Thank you. So I am going to talk to you about hematopoietic stem cell transplant and sort of a little bit about how did I get here and what do I do. It started way back when. What led me to medicine, I actually grew up in a very small town in northern Kentucky near Cincinnati called Fort Thomas, Kentucky. Based on this picture, I apparently started out wanting to be a ballerina, but that certainly didn't fly. But I've been told by family and family friends that ever since I was 5 years old, I was very clear I was going to be a doctor. I don't have any recollection of that. And I certainly, none in my family are physicians. My mother was in healthcare, and I had a maternal grandmother and maternal aunt who were in healthcare as dietitian and nurses respectively. But my father was in business, and I have a younger brother who is way smarter than me, but is, works as a chef. And somehow I did have my tunnel vision and kept going forward to become a physician. So I have been doing this a long time. I graduated from high school in 1989, and I actually had I mentioned I was from a small town. We had 150 in my graduating class, and at least 4 of us are physicians. We got a couple dentists and a couple lawyers in there as well, but it was a very, still a fairly small class to have that many people actually ultimately go on to medical education. I went to college at Duquesne University in Pittsburgh. There were 2 reasons for that. The first is I was given a radius of how far away from home I could go, and that was on the outer edge of that. And the second was they had a program in undergrad that we actually got credit for, which was shadowing with a resident. There was a hospital that was actually adjacent to campus called Marcie Hospital. And so we got to go spend, 3 hours a week for, 4 to 6 weeks being on call with a resident. And so it had a lot of things that I think you guys are doing in terms of shadowing here, although obviously we were not in a pandemic. But it was one of the only programs that I could find of its kind way back, 25 years ago, almost 30 years ago. Wow. I went on to medical school at the University of Kentucky. In part, they gave me a scholarship, and medical education is expensive, and that's not something that you walk away from. I stayed there for residency. They had a very unique program that was called an accelerated internal medicine residency program. So actually my 4th year of medical school was actually combined with my intern year. So I, was starting as an intern while I was finishing up my 4th year of medical school classes. I stayed on and did a chief resident year in internal medicine, and then went on to do my fellowship During my chief resident year, I actually spent some time in a basic science lab, learning about things like flow cytometry, and actually how to target different leukemia cells. The person who was my mentor at that time actually now directs the transplant program at Wake Forest Baptist. So we both wound up down here. During my fellowship at Northwestern in Chicago, fellowship is an interesting experience no matter where you go. The first year of fellowship is like going back to being an intern, where you're, sort of up all night, busy on clinical work, and not really getting to do some of the other things that we learn in fellowship, like research. And as I was on my initial rotations, it was, the leukemia service and transplant service at Northwestern at that time were combined. And those were the patients that I was really drawn to. I had some experience, obviously, from my, some of the research that I was doing in my chief resident year, as well as I actually did some moonlighting on the bone marrow transplant unit at the University of Kentucky. And so knew that I had some interest in that. Ended up staying to do an additional year of fellowship in transplant. That was a purely clinical year. Part of the reason that I did that is during my second and third year of fellowship, my second year early on had a project that I was working on about how to try and expand stem cells, and ultimately submitted a grant that got funded. And so had to spend that third year in the lab, even though by the end of my second year realized that I was not going to be a lab scientist. But again, you don't turn down money, and you work through those things. And so I stayed and did an additional year that was just transplant, and was on our inpatient unit, which was now separate from the leukemia service, for basically 48 of the 52 weeks in that year, as well as being on call every other weekend for that year. And during that time, I was also getting my Master's of Science in Clinical Investigation. And so that was because as I'd said, I learned the lab was not where I wanted to be, but research is. And so I ended up doing that to try and get some additional skills, some additional statistical courses, epidemiology courses, to be able to really hone that skill. And then also learning how to write clinical trials, what's necessary from regulatory, IRB, all of those different things. I moved further north for my initial faculty position, and I was an assistant professor at the University of Minnesota in the HOT division. At that point in my career, the Center for International Blood and Marrow Transplant Research was merging, and actually at the time it was the IBMTR, but it was merging with the National Marrow Donor Program's research arm, and formed the CIBMTR. The National Marrow Donor Program, which is now called Be the Match, actually is based in Minneapolis. And so they needed clinical physician, scientific directors on the Minneapolis campus, in addition to the Milwaukee campus, which is where the IBMTR, now CIBMTR, is primarily located. And getting into that was actually, it's probably been the greatest joy of my career, is actually working within the CIBMTR, doing outcomes analyses for transplant patients. I ended up, while I was there, also developing within the CIBMTR a small phase 1, phase 2 oligocenter clinical trials group called the Resource for Clinical Investigation in Blood and Marrow Transplant Research, or the RCIBMT. We use a lot of acronyms in transplant. But the RCIBMT was really designed to utilize the strengths of the CIBMTR and the NMDP, as well, to allow us to develop some scientific trials that ultimately would need to go into the large national transplant clinical trials network called the Blood and Marrow Transplant Clinical Trials Network, or BMTCTN. For personal reasons, my now ex-husband was finishing his residency at Minneapolis, did not want to stay on faculty there, and so we ended up moving to the Moffitt Cancer Center in Tampa, Florida. So I was there for 6 years. And while I was there, not only was I a clinician, I also directed the research program for the transplant program there. Ultimately moved to North Carolina in June of 2015 and have been here since that time. I became a professor in hematology oncology. However, in May of 2020, hematology and oncology split into two separate divisions. And so that's where it became just hematology. I mentioned the CIBMTR, and I'll talk a little bit more about some of the research that we do with them as I kind of go through this a little bit more. So how do I spend my days? A lot of meetings since I became the director of the program. There's a lot of administrative work that has to be done, but most of it is still clinical and research activity. I wanted to give you guys a little bit of a background about transplant in general. So transplant is the practice of treating malignancy and bone marrow failure syndromes with hematopoietic stem cells. It's also being utilized in certain, and particularly this is far more with pediatric diseases, but inherited metabolic disorders or inherited hemoglobinopathies. So patients with sickle cell disease are considered at times for allogeneic stem cell transplant. Hematopoietic stem cells are those, they live in the bone marrow. They develop into red cells, white blood cells, and platelets. We, as the field has continued on, have really changed to using the terminology of HCT with hematopoietic stem cells as opposed to BMT, meaning bone marrow transplant. And a lot of that has to do with the fact that we rarely collect bone marrow as the source of the stem cells any longer. We usually give patients medication, which is a colony stimulating factor to grow the stem cells and push them out into the bloodstream so we can collect them that way. Transplant, there are two types. We can do autologous, which is a self-transplant, or allogeneic, which is a donor transplant. And so the disease is really what drives what type of transplant we're going to do. So if somebody has a leukemia, their stem cells are damaged. So I can't use their stem cells to serve as the means of transplant and do an autologous transplant. I need to find cells from somebody else. And that process involves looking at the HLA genes, or human leukocyte antigen genes, and matching those between a patient and a potential donor. Our first choice still ends up being a related donor, so a sibling. In rare instances, double cousins would be an option as well. But the next choice becomes a matched unrelated donor, and those are found for us through the National Marrow Donor Program that I mentioned before. What I'm showing here actually is a slide from the CIBMTR. They do track transplant activity. In fact, centers are required to report all donor transplants to the CIBMTR. as the CIBMTR has the contract for HRSA that monitors transplant center outcomes to make sure that we're taking good care of patients. But this activity is from 2019 and really shows you the breakdown of allo and auto transplants during that time. For me, over time, what I have seen, particularly over the past 2 to 3 years, is our autologous transplants for non-Hodgkin's lymphoma have been declining. And that's because of another cellular therapy that's come along called CAR T. That is a whole nother area of talk, and certainly something that I'll be happy to answer questions on, but not something that I necessarily focus in, although it is under the guise of our transplant program here at UNC. So what I'm showing here is just a little bit about our program itself at UNC. This program was established in 1992 by Dr. Tom Shea, and Tom retired in the end of September of 2019. Transplant itself, the first successful transplant was done in 1968. So for you all, that seems like a really long time ago. For me, that's not that long of a time ago. And this program has been in existence since 1992. We currently have 7 attending physicians within the program. 4 are primarily clinical, like myself, and 3 do primarily bench research. We also utilize advanced practice practitioners. We currently have 7 APPs. They focus only in transplant, and our group of APPs has been exceedingly stable. All of them, well, we had one leave recently because her husband got a job in New Mexico. She did not want to leave. But all of the rest of our APPs, except for her replacement, have been with us for more than 5. They've actually all been here longer than I have, although one started a few months before that. We utilize 4 pharmacists that are transplant-focused pharmacists. We have 11 transplant nurse coordinators. 2 of them focus on our CAR T patients, which is that other cellular therapy I was talking about. We have a quality transplant nurse coordinator because we are it's necessary for us for all of our accreditation as a program to have a detailed quality program within under our BMT group. And then we have a program manager. We have 3 financial coordinators. One thing that's very unique about transplant and CAR T, as opposed to most other patients coming to the hospital, we have to get approval for transplant. And they actually have to have approval for transplant, at least preliminary approval, before they can even be seen in consultation. And so that is very different than somebody else coming to the hospital. And so our financial coordinators work on, 1, making sure the patient can be seen, 2, getting that transplant authorization or CAR T authorization, but they also have to verify that whether or not a patient can participate in a clinical trial, simply because if the patient's insurance doesn't have clinical trial coverage, the patient participates in a trial and we haven't verified that, they're going to be on the hook also for the cost of their transplant and a transplant hospital stay. So they're a huge part of our program. We have 1 business application analyst and 2 data managers that are responsible for our program, maintaining all of our data, as well as reporting all of our data to the CIBMTR. And as I mentioned, the CIBMTR data is then utilized to benchmark transplant programs for HRSA, as well as for insurance companies that allow us to be able to transplant patients. And then we also have a hospital clinical director who is an RN, and Sam and I, partner between the physician APP group and all of the hospital employees that are within the transplant program. So the transplant process, this is an extremely simplified algorithm, but they're referred to us for consultation. And as I mentioned, we make a decision based upon the disease as to whether or not it's appropriate to consider somebody for allo transplant or auto transplant. The auto pathway is a little bit easier once they are designated, that we're going to proceed forward with an auto, and the patient is, interested in proceeding and willing to proceed. They have to have sort of three things that allow them to go forward with transplant, and that's ascertained in the pre-transplant workup. The first is their disease has to have responded enough. And auto transplant really is just treating the disease with high doses of chemotherapy. The second thing is they have to be healthy enough for transplant. I am going to give them high enough doses for chemotherapy that if I didn't give them cells back, it's going to destroy their bone marrow. So they're not going to have an immune system. They're not going to be able to make blood. But those high doses of chemotherapy obviously can have toxicities on the heart, the lungs, the kidneys, the liver. So we have to make sure they're healthy enough. The third thing that is critically important for going through transplant is having a caregiver support system. So our autologous transplant patients actually have to live locally until about 30 days after their cells have been infused. We'll talk about how that differs from our allos, but for the autos, during that, there's about 2 weeks after they've gotten out of the hospital, where they're living locally with with a family member, friend, that is staying with them 24/7 for that couple of week period of time. So once all three of those are identified and meet criteria to go forward, we then collect their stem cells. And that process involves giving them growth factor under the skin as an injection that is specific for white blood cell or granulocytes. We collect the stem cells through a process called leukapheresis. The cells are counted to ensure we have enough for successful transplant. And then a preservative is added to those cells, and they're cryopreserved and put in a freezer. The patient is then admitted for transplant for their high-dose chemotherapy. On the allo side, we have a couple of extra steps. And so the patients not only need to have all of the same things, their disease responded enough, be healthy enough for transplant, and have an adequate caregiver system, they also have to have a suitable donor for transplant. The donors can be matched related, I mentioned, which is usually a sibling, matched unrelated donors. And then we have sort of the next tier of donors, which is something called a haploidentical transplant or a half-matched transplant. That's usually a family member. So it could be a parent-to-child transplant. It could be a sibling who's just half-matched. And then umbilical cord blood stem cells, as well as mismatched unrelated donors, are all utilized to be able to get a patient to transplant. With all of those stem cell sources, we now can probably find donors for about 90 to 95% of patients. While we're doing the donor search, the patient is going to continue on treatment. It can take up to 2 to 3 months to find a suitable donor to be able to go forward with transplant. The caregiver aspects for an allo transplant, these patients have to live locally within 30 minutes of UNC's transplant program until about 3 months after their cells have been infused. So for these patients, it's about a 10 to 12 week commitment from a family member or friend or several that can share the load to stay with that patient 24/7 until we're ready to let them go home. If they live locally and, if they live close enough to the transplant center, they still have to have that caregiver, but obviously could go to their own home when they're discharged from the hospital. So the other thing on there is this functional assessment visit. So a functional assessment visit is something that we implemented for our allo transplant patients to make sure that we're identifying any organ injuries that may need addressed prior to transplant. But it also looks at psychosocial issues, because the donor search is ongoing, but we're going to need that long-term caregiver and long-term caregiving plan to be able to get somebody through an allo transplant. There are also a lot more complications that can happen with a donor transplant. And so making sure that a patient has a good track record of compliance, they're not using substances, including cigarettes and alcohol. Those are all critically important to the success of transplant. And so that functional assessment visit is done within 2 to 3 weeks of the consult, so that we can start working on any of those issues and help mitigate them, so that they're able to go forward with transplant once we find a donor. So all of those things are kind of happening in parallel. And then once we've identified the donor, they will get their pre-transplant workup to make sure they haven't had any additional problems that have developed since while they were continuing chemotherapy. And then those patients will be admitted for transplant. I mentioned that the patient will receive several days of high-dose chemotherapy. This may also include something called total body irradiation. And then the stem cells are infused. The hospital stay ranges anywhere from about 2 to 6 weeks on average. For the auto transplants, it's about 2 to 3 weeks. For the allo transplant, it's about 3 to 6 weeks. As I mentioned already, the patients have to live locally with the different timeframes based upon the type of transplant. And the patients are seen as frequently as we need to see them for their health care. So early after transplant, particularly for the allo patients, these patients may be seen in clinic 3 times a week. On occasion, they may be seen 7 days a week. We know that anything that we can do in the outpatient is better, because it pushes patients to be more active. They are able to generally sleep a little bit better when they're not in the hospital, and they tend to eat a little bit better when they're out of the hospital. Later post-transplant, the auto transplant patients really aren't seen that much more frequently once they've kind of hit that 1 month post-transplant mark. They are seen about 2 months after transplant, and then 6, 12, 18, and 24 months, because that corresponds to all of the vaccinations that they need. So these patients, we wipe out their immune system. They need revaccinated for all of those childhood illnesses. So measles, mumps, rubella, which can't happen until 2 years after transplant, but inactivated polio, hepatitis B, all of those vaccines have to be given to the patient. And so we tend to do them at those time points. And so for the autos, that's when they're seen. The rest of their care transitions really back to their primary oncologist. The allos are with us forever, unless their disease relapses, in which case they often go back to their primary oncologist. But our patients are really seen every couple of weeks between 3 months and 6 months from transplant, then monthly, or every 4 to 6 weeks from that 6 months to a year after transplant. And if things are going really well, then they're seen every 3 months for that next year or so, and then hopefully we can space things out further. But there are a lot of transplant complications that can happen. I mentioned organ damage. Organ damage is really an early transplant complication from high-dose chemotherapy and with or without radiation. Graft rejection is something that we can see. It's fairly rare. Autologous transplant patients, I've seen it once in my very long period of doing this. And the patient had an overwhelming infection when they rejected their own cells. In the donor setting, it depends on the type of donor we're using. It depends on if it's all peripheral blood stem cells or if we're using a graft that has been collected directly from the bone marrow. Graft versus host disease. This is only seen in donor transplants. It is when the donor stem cells are attacking the patient's healthy body. And so it's an immune-mediated reaction from things that are different between the donor and the recipient. If we were thinking about this like a kidney transplant, it's the patient's immune system attacking that donor kidney, and that causes rejection of the kidney. In this instance, what we're seeing is that the donor stem cells are trying to reject the patient. And acute graft versus host disease occurs in about 30 to 40% of our patients. It has different levels of severity, and it can be fatal. Chronic graft versus host disease is far more common. It's later. It doesn't really start until around 2 to 3 months or later after transplant. And only about 10% of people will develop it beyond a year after transplant. But it can affect virtually any organ of the body. So they can have eye damage, they can have skin damage, they can have severe dry mouth, they can have liver changes that are more like cirrhosis. And so these complications are things that we're trying to prevent from happening, treat, as well with medications called immunosuppressive medications for treatment and prevention of graft versus host disease. Those immunosuppressive medications lead to the next part of the next major complication of transplant, which is infections. So bacterial infections are very common. Almost half the patients will have at least one bacterial infection within the first 3 months after transplant. And these are usually bacterial infections in the bloodstream. But fungal infections and viral infections are also very common. And the viral infections are generally infections that are from viruses that the patient has been exposed to, but has been controlled by their own immune system. So a virus called cytomegalovirus, a virus called Epstein-Barr virus. Most of us get exposed to that as we're growing up. And those viruses can reactivate, can cause disease, and can be fatal. Infection actually does account for the primary cause of death in up to, in about 20% of patients by 3 months after transplant. So the clinical management of my patients involves me understanding their cancer or their bone marrow failure syndrome, immunology from graft versus host disease perspective, and a lot of ID from the standpoint of the immunosuppressive aspects of things. When you tack in the organ damage that we can cause and how quickly things can change in these patients, there's a little bit of ICU care and a lot of general medicine that's necessary to manage these complicated patients. So moving from my clinical work, I do research activity as well. Observational research. So I mentioned that UNC has a transplant database. Our transplant database goes back to 1992 when the program started. So we do have information on all patients that we have transplanted. So asking questions of that database is one area that we can do research. The second is my other love, which is the CIBMTR. So CIBMTR collects data from about 450 transplant centers worldwide. There are hundred thousands of patients in the CIBMTR database for researchers to ask questions. And so, as I mentioned, I'm a scientific director for them for their Infection and Immune Reconstitution Working Committee. And so anybody who has a question that's related to those two things, that question gets shunted to my working committee. The CIBMTR has statisticians that work solely with CIBMTR data. And the working committees will effectively determine the scientific agenda for the CIBMTR each year at our annual meeting in February. So for this upcoming year, my working committee for our February meeting in 2022 we received 25 proposals for research. And so trying to figure out, are they things that can be done with the data that we have? Has it already been asked? And just they didn't find the reference. Is it something that's in process? And usually we whittle it down to about 1 to 3 proposals that will go forward each year. My committee has been extra busy because of COVID, and there's been a lot of COVID proposals that have come in, and those actually are separate from that 1 to 3 that we usually pick each year. The other aspect is prospective clinical trials. So investigator-initiated clinical trials are certainly things that are done for transplant patients, for oncology patients in general. And those generally are single institution studies, or maybe 1 or 2 institutions. One of the investigator-initiated trials that I have conducted here at UNC actually was looking at patients who were getting an autologous transplant for lymphoma that had a specific marker on the lymphoma called CD30. And what would happen is they would get their transplant, standard transplant, and about 3 weeks after that transplant, we would actually give them also a CAR T product that targeted specifically that CD30 marker on their lymphoma. We probably have about 7 to 10 investigator-initiated clinical trials going on right now within the transplant and cellular therapy program. We are also part of that BMTCTN that I mentioned. There is a consortia of 5 centers within the Ohio State Consortia, and UNC is part of that, but the BMTCTN has about 20 core centers or core consortia that are involved in developing trials and running these trials. And the BMTCTN has enrolled more than 15,000 patients getting transplant into clinical trials since its inception in 2001. And then obviously there are industry clinical trials that can happen as well. So a pharmaceutical company is trying to investigate something that is for treatment of graft versus host disease is a great example. Then we may participate in those trials and have that as an option for our patients. And then I have a lot of administrative. Our programs must be accredited by the Foundation for the Accreditation of Cellular Therapy, or FACT. We get inspected every 3 years, and the UNC program has been continuously accredited since 2005. And then I mentioned earlier the federal reporting requirements, which actually go through CIBMTR to assess our survival outcomes. These are 1-year survival outcomes, but it's a 3-year rolling analysis. And those get reported to HRSA for the Stem Cell Therapeutics Outcomes Database. And so the most recent analysis that we got is shown below, and I'm happy to say that UNC has the best 1-year survival of these programs that are local to UNC, fairly local to UNC area. So when I was going through residency and thinking what I wanted to do, I had to figure out which rotation really was the most enjoyable for me, and obviously which is the least enjoyable. You want to do that during medical school as well. I was miserable on my pediatrics rotation and my OBGYN rotation, so that was nowhere that was I going to consider that. But really enjoyed my internal medicine rotations, and I actually got exposed to oncology during my internal medicine rotations in medical school, which helped me decide that I wanted to do that from a residency perspective. Within the residency, figuring out what you enjoy is important. For me, I enjoyed infectious disease, I enjoyed oncology, and I enjoyed ICU medicine. I get all 3 of those with stem cell transplant. And so that's really how I ended up getting to where I am as a transplant physician. I do think that it's important to think about whether or not you want to specialize. There are, you're going to encounter lots of different problems, both when you're going through medical school on rotations, as well as during residency. And if there's something that's more interesting to you, listen to that, because you've got to stay energized and really enjoy what you're doing clinically to be able to continue to do this with the long hours, the lack of sleep, all of those different things. And then the other decision that you make as you're finishing up residency and or fellowship is, how do you want to practice medicine, or do you even want to practice medicine in a traditional sense? So academia is what I've chosen to do. So I have clinical and research activities as well as my administrative activities. Private practice, you're only going to be taking care of patients. And that is, something that people have to make that decision of what is right for them. There's probably a little bit more control over your time, because you end up being in a practice with lots of people, so you can cover each other. And so it's maybe a little bit easier to take vacations or things like that. But you won't be doing any research outside of maybe occasional industry sponsored or cooperative group clinical trials. And then other is things like being a physician within industry. So working as a medical director within a pharmaceutical company or a clinical research organization. And that's not going to have patient care, but that is going to be a lot of research activity and being able to, improve the life of patients just from a different perspective. You're not committed to only one path. You obviously can change. I will say that it's probably a lot harder to go from industry into private practice or academia. And it's probably very, more difficult to go from private practice into academia as well, just because you've not spent as much time in things like the research aspects of things, which are really often necessary for academia, unless, some of your decision is you want to just be something, you want to do something like hospital-based medicine and be a hospitalist, where you are doing a lot more clinical care. It's hospital-based clinical care, and you may or may not need to do research, but hospitalists are certainly used in academic hospitals. So I think that is my last slide, and I talked quite a bit more than I had anticipated. I'm going to take the slides off of here so I can see people's faces if they want to ask questions. I put everybody to sleep.
Hey, I have a question.
Sure.
But it's more specifically on like transplant with family members and all that. So I was wondering, like, when you do a transplant, when like a donor is accepted to do the transplant, is that donor more likely to